Good afternoon, everyone. We're back again for the final session of this week, where I promised you I'd come down to Delivery Suite. So with social distancing, I've brought along a few members of staff so that we can help to talk about various bits of labour if you were to come onto Delivery Suite. We're also going to talk about induction as well. But what we thought we'd do is start with Rhian, who's going to talk to you. She's one of our Delivery Suite coordinators and also obviously hands-on midwife, looking after you in labour. And then I have the other staff that I'll introduce along the way, but we've got anaesthetists, obstetricians, we've got Di, our lovely induction midwife. We're going to talk through things. So what I'll do is we'll do a segment of information and then we'll encourage you to invite, we're going to invite questions about that. And then answer those questions before we move on to the next one. So bear with us, and we're going to have to pass the computer about a bit so we can still socially distance. So I'm going to hand you over to Rhian.
Lovely, thank you. Welcome everybody. Like Wendy's introduced myself already. I'm Rhian, one of the Delivery Suite coordinators here at the John Radcliffe, and I also work clinically as a midwife. So we'll possibly maybe looking after you when you come in labour, or I could be coordinating Delivery Suite on that day. I've been watching these podcasts as they've been coming out in the last week. So you've all been getting a little bit of a feel of what's happening and how things are working here at the John Radcliffe. And also I know you've gone through the different stages of labour and things, what to expect when you come in labour. So what we thought we'd do today is just show you one of our Delivery Suite rooms so you can have an idea of what to expect when you come in here. I know you've been upstairs onto the spires and seen the lovely rooms that we have upstairs there. On Delivery Suite, we have 13 birthing rooms here, and we also have a pool room available as well, which you may well be aware of. So if you were needing to come to us on Delivery Suite for extra monitoring, for whatever the reason may be, then we can use, if it's deemed okay by our obstetricians, if they're happy for you to use the pool, we can use telemetry to support those women who are able to use the pool but not quite as low risk as being able to go to the spires. So I'll just show you some of the things that we have in our delivery room so you can have an idea and a feel for what we've got here. I'm just going to lift this monitor up and just show you what we have here already. So within all our rooms we have birthing balls and bean bags. Sometimes we have to scurry around to find, if we haven't got one in one room, they might be available in other rooms. So we need to make sure we've got what you need to support you in labour. These are some of the things that will help. So we've got birthing balls of all different sizes to suit different heights of women that you can use throughout the course of your labour. We do encourage women to stay upright and mobile, even on Delivery Suite. Just because you're here, you might be a little bit higher risk in your pregnancy, but you're here and we're looking after you because we need to monitor you that little bit more. But we still encourage you to be active in your labour, work with you for you to have the birth experience that you want. So we do encourage you to remain mobile, and being upright will help to bring that baby down the birth canal and keeping you active as much as possible. One of the monitors, we've got new telemetry monitors available in every room now. These have been with us in the last 6 weeks or 2 months, and each room has a whole new CTG monitoring system, which is fully portable. So these come off, they're wireless, and we can monitor your baby safely by attaching these onto your tummy. Wendy will demonstrate that on her tummy now. So one will sit to pick up your contractions on the top, and the lower one will be picking up your baby's heartbeat. You would normally have a couple of sort of elasticated straps holding those in place. But you would still be able to walk around your room quite freely. You would be able to walk out to the bathroom, use the bathroom. You could even, all being well, possibly if you're not got any drips or cannulars in, could go out and have a shower, a warm shower, which may help in the early stages of your labour. So that's our new telemetry system, which is wonderful. Over in the corner, we've got a whole team in here today of doctors, midwives. As you can see, I'll just give you a little flashlight of who's here, husbands and obstetrician. Going over to this side of the room, we have a bed in every room, but again, we do encourage women not to lie flat on their backs whilst in labour. We do encourage you to, if you need to have a little rest and lie down during the course of your labour, then perhaps lying on your side is better than lying directly on your back and low on your back. These beds can be adapted to different shapes and heights to support you in kneeling positions or in an armchair position. So they're quite adaptable rather than being a flat bed to lie on. It can also be elevated upwards so that you can lean over the beds. So if you want to sort of stay on your feet and have something at a higher level to lean over, that can happen too. You might have seen up on the spires, they had gas and air, and they were in portable oxygen cylinders. Here we have piped gas and air, or Internox, whichever you wish to use, and that will always be available to you. We have two different methods in which you can use the gas and air, and that's with a mouthpiece, or we do have masks available as well if women prefer to do that. But most women prefer to use this method. What else have we got here? We've got, when you come into these rooms, we encourage you to make yourself at home for you and your partner. So bring your belongings in. If you want to bring your own pillows in, that's absolutely fine. But we encourage you to make yourselves at home, and just this room will be yours for the duration of your birth. We have aromatherapy diffusers, which you can see here. I don't know if you can see the changing light colours. So at night time, it's really lovely because you can really have the full effect of the changing colours of that diffuser, and we can also supply aromatherapy oils to support you in your labour as well, which will help to relax and calm and soothe. And you can use it as foot baths or for massage as well. So something your partner could be involved in massaging your back or your arms or your shoulders to help you sort of through the process of your labour. Hello everybody looking happy and smiley over there. They've all got their lipstick on ready. In the corner over here we have, it looks quite a scary thing, but it's actually just a platform with light and a heat supply and some oxygen. So if we had a baby that we knew might need a little bit of support when it's being born, sometimes we bring one of these into the room ready. We turn the lights on and the heater on, so it's a nice warm spot for your baby to come on to. And sometimes we need to give your baby some oxygen. So this is what we call a resuscitator. Sometimes we bring that in very much at the last minute if we think your baby might be requiring a little bit of help. And you may find that when that comes in, some bleeps and noises and lights sort of are sort of being made in the background, but just to be aware that it's just us turning things on and checking the systems before they're ready for use. I'm just going to go to Wendy and think, is there anything else that you can think of that I need to tell?
I don't think so. I think just the main messages are we do everything we can to support you to have as normal an experience as possible. We've got some information on the walls as well. So we use, we have positive birth affirmations that people have made, things that they've found helpful to concentrate them, to remain positive and to encourage breathing. So we have a full range of techniques to help you. We've talked about the things that you can do in terms of massage and water and aromatherapy. We talked about pain relief yesterday, the gas and air, the diamorphine or Meptid. And in a minute, we will move over to Jenny, our anaesthetist, who's going to talk to you about epidurals. But I just wondered if there's any questions that you had for us before we move on to the next session about sort of the room setup or things that Rhian has raised. So, Coral, you've said, you just mentioned partners. Will you only be moved to delivery room in advanced stage of labour, or will partner to be able to be in the same room at this stage of labour? So basically, when you are felt to be in established labour, and we think, that you require one-to-one care in labour, that's at the time that your partner would join you. So if that's at one of our standalone birth centres like Wallingford, that's in the Spires, or that's here on Delivery Suite, at the point that we're saying we need a midwife to look after you and be with you all the time, that's when we invite your partners to be with you at that point. Just check if there's no more questions. Okay, so I'm going to hand over now to Jenny, who's going to talk to you about the epidural side of things, and maybe you'll have some more questions for Jenny. So just ask as you come along. Somebody's just quickly come in as, would this be the same as the midwifery-led unit? Absolutely. And Katie, you said, is there usually a place for partners to lay down and get some rest whilst you're in labour, if things are going slowly? They can, if you're not using the beanbag, they can use the beanbag, but we do have a chair in the room if you're not using it. And very last question before I go to Jenny, it says, do most of your rooms have windows? As someone said, quite a few at the JR don't. We only have 2 rooms like this that have big windows. We have 2 rooms that have much smaller windows, but you are right, the majority of our rooms don't have windows. Some people don't like that, but it can actually be very, very cosy and nesting because you can dim the lights to help you feel relaxed and sort of create that safe space for yourself. So don't be put off about the windows. So I'm going to hand you over to Jenny now.
Hi everybody, afternoon. My name's Jenny. I'm one of the specialist team of anaesthetists here at the JR who look after ladies on the maternity, and I'm just going to go through a few things about epidurals and anaesthesia, and I can answer any questions you've got. So firstly, I think to reassure you, I know some of you have been worried that there may not be enough anaesthetists around because many anaesthetists have been called in to work in intensive care and looking after patients who are very sick with COVID. Here at the JR, we're really lucky. We have a team of specialist obstetric anaesthetists, and we have ring-fenced people who are here to work and to look after you. We've also made some slight changes to how we work, so there are slightly more of us around, because inevitably some of the changes we've had to make to keep you and your partners and your babies and the other women and staff safe have meant that things take a little bit longer to do than they have done pre-COVID times. So I'm just going to talk a little bit through what would happen if you wanted an epidural, and then I'm happy to answer any questions. So when you and your midwifery team decide that an epidural is right for you, that may be because that's what you've decided before you've come in labour, or it may be to do with how labour is going and something that you decide together. There are a few things that we need to do before we can give you the epidural. So sometimes we need to have a look at blood tests that have been done and check that it's safe. And we will always need to come and speak to you and just talk about specific factors to do with you and your health, and also to explain what we'd do. And basically, we need to put in a cannula. We need you either sitting or lying on your left side, and then we'd clean your back and site the epidural. This can sometimes take a bit of time, sometimes 15 or 20 minutes. And once the epidural's in, it does take about 20 to 30 minutes to reach its maximum effect, although you'll start to feel the positive benefits from it long before it's reached its maximum effect. Once the epidural is in and working, we'll connect you to a pump which allows you to self-administer the epidural for the rest of the course of your labour, although there'll be an anaesthetic team available should you need us at any point if there are any queries or things are not quite as planned. Anything else that I should go through, Wendy, for ladies? Oh, one thing I forgot to mention, ladies, sorry, before we come in as well, it's really important that we're able to know that your baby as well. And so if you've literally just arrived on the delivery suite, we will need 20 to 30 minutes where we monitor your baby to make sure your baby's really happy before we can come and site your epidural. And also during the time that we're siting the epidural, the midwives need to keep an eye on your baby again to make sure your baby is happy and well. And sometimes that can mean that the positioning can be a little bit difficult. So again, we just have to work together as a team, the midwives and yourself and us, to make sure everybody's safe and well.
Great. So do you want to see if we've got any questions sort of down here, things that you might want to look for? So there's a question, I'll come back to Siobhan's question, but a question from Elizabeth. Elizabeth, you've asked, do you always get an epidural if you want one? Due to your previous experience, you don't want to be convinced not to have one. You don't need to be sorry, Elizabeth.
So in answer, Elizabeth, the answer is yes, we can almost always provide an epidural. The only time when we couldn't is very occasionally if ladies are labouring very quickly, then we're not able to provide an epidural quickly enough before the lady actually has her baby. But there isn't any stage of labour when it's too late to have an epidural. So even sometimes if a lady is 9 or 10 centimetres dilated, depending on the circumstances, even at that stage in the labour, we can provide epidurals. And we would always be guided by your wishes and what you and your midwifery team have decided is best for you and your baby.
Thank you. So if we come down, so we've got a question from Vicky is, will there be fans in warm weather? Yes, Vicky, in short, there will be fans in warm weather. If you are concerned, then please do bring your own with you. That's equally all right, because sometimes there is a fight over them because everybody wants them. There is normally enough for every room, but yes, it can get quite warm in here.
So Joanna, yes, in answer to your question, if you've started off on the spires and then you decide you'd like an epidural, you will be moved down to the delivery suite, but it's all within the same building. But yes, we can only provide an epidural service here on delivery suite. Ella, I hope I've already answered your question, when is it too late for an epidural? But essentially it's too late if we would give you all the risks and none of the benefits. So essentially, if you're literally about to deliver your baby, then we wouldn't be able to give you an epidural at that stage. But apart from that, as I said, any stage in your labour, even when you're fully dilated, sometimes it's appropriate and the best thing for you and your baby. And we can even provide an epidural at that stage. Oh, so Zoe, Amy, yes, your pre-op assessments are now being done over the telephone. So we're trying not to have people attend hospital if they don't need to. And so we'll be in touch with you, yes, but that will be done by telephone. Emma, I think, again, hopefully I've answered that question, but if you've got anything more specific, then please ask. So the feeling coming back after labour is a little bit variable, and it depends a little bit how long you've had your epidural in and working for, and whether we've had to top your epidural up, for example, if you've needed a forceps or a Von-Tooth delivery. So sometimes it can take 3 or 4 hours for the feeling to come back entirely, sorry. But you'll start to feel the feeling coming back usually after an hour or two when we've turned off the epidural pumps. So Georgina, can you have a partial epidural? So yes and no, which I know is not a very helpful answer, but I'll explain a little bit more. So the epidurals that we provide in labour use what's called a low dose type of anaesthetic, and our aim would be that you would be able to move within the bed and move positions. Some ladies, if their muscles feel strong enough, can even stand supported by the side of the bed. But we don't recommend that you walk about once you've had your epidural in. The reality is, as time goes on after many hours, the epidural does tend to get a little bit, makes you a little bit less able to move about. So ladies who've had an epidural for many hours sometimes find that they're less able to move than they were at the beginning. So Cheryl, in answer to your question about possible risks to the baby with an epidural, so the drugs that we give you into the epidural aren't passed to the baby. However, you're absolutely right. Sometimes the baby's heartbeat can drop after we've put an epidural in. This can sometimes be related to the epidural and sometimes isn't related to the epidural. And the way it can be related is if your blood pressure has dropped. So that's part of the reason why before you have an epidural sited, you need to have a drip in your arm with some fluids running so that we can treat your blood pressure if it does drop. And also, once your epidural is sited, initially we'll measure your blood pressure every 5 minutes to ensure that it's stable. If it does drop, then the drugs that we can give you to treat it and bring back up to a normal level. Apart from that, the epidural isn't known to have any negative effects on the baby. And in fact, if you look at ladies, particularly ladies in difficult labours, there's some evidence that epidurals may actually be helpful for babies.
Popular.
So Yvonne's question about pools, I think it's probably better if you answer.
Yeah. So Yvonne, you've asked how many pools there are on Delivery Suite. We have 1 pool on Delivery Suite, and in one of the films that I posted last week, I think you can see the pool then. If the pool is busy on Delivery Suite, there are things that we can do to help support you, hopefully, and it will become available during your labour. Because generally these things work out quite well, and somebody's perhaps just given birth in the pool room when somebody comes in wanting the pool, and thus we just juggle things around, keep you going until we can move the woman, clean the pool, and get it ready for you. But I don't think there's many times when the pool is not available when it's requested on Delivery Suite.
Lauren has asked if an epidural would be given to someone who has a heart condition, as she's been told by her midwife that this is common practice. Yes, Lauren, your midwife is right. One of the benefits of an epidural, as well as taking away pain, is that it helps to keep blood pressure under control and helps in some ways to minimise the stress on your body and in particular on your heart during labour. And so there are some heart conditions where we recommend that a woman considers an epidural. However, we can only ever provide a lady with an epidural if that's what she wishes. So there are times when we might counsel you that we as clinicians believe it's a good idea, but ultimately the final decision is always going to be yours. So Yvonne, in answer to your question, can you use the pool with an epidural? No, you can't. But you could start in the pool if that's what you wished, and then if you decided that you then wanted an epidural, then it's perfectly possible to get out of the pool and have an epidural at that stage. Katie, we'll come back to induction. Yes, we haven't talked about that yet. So Rebecca's asking about the pre-op assessment. So essentially we go through some of your medical problems, any drugs that you're on, and we explain the procedure in terms of the anaesthetic when you're coming before you're having your cesarean section. But as I said earlier, we're doing those by telephone consult now, although we're just moving to do some in a very similar way to this, so we can have a face-to-face consult with ladies. Elvira,
I think, sorry, it was Caris.
Oh, sorry, Caris, I do apologise. Can an epidural slow the labour down? So again, this is a yes and no question. So if you're in active labour, in what we call the active phase of labour, there's no evidence that the epidural slows the labour down. However, a lady who's in spontaneous labour, who we put the epidural in very early in the labour, there is some evidence that if you're what we call before the active stage, that can slow the labour down. I think the other thing that is important to note is that sometimes if you're already having a long and slow labour, you are more likely to need or to want an epidural. Elvira has asked us a question, is it true that epidurals can cause worse tearing? I think that's probably something for the midwifery team to answer rather than me.
Sorry, the evidence base is not that you're going to increase the risk of tearing. It's just sometimes you need a little bit more help with birthing your baby, which if we're having to give you a little bit more help that Mena will go on to, sometimes that can lead to a bit more tearing. So it's not necessarily about the epidural itself, it's just about the help that we have to give you sometimes to birth your baby.
So Emma has asked a question, is it common that we give an epidural for a cesarean section anaesthetic? So there are three types of anaesthesia that we provide commonly where the lady stays awake. One is an epidural, and if you've had that in labour and then needed a caesarean section, most commonly we would top it up. If you're coming for a planned caesarean section, the most common anaesthetic is either a spinal anaesthetic, which is similar to an epidural, but a one-shot injection, or occasionally would do what's called a combined spinal epidural, where you'd have both together. But again, that will all be explained to you at the pre-section visit if you're having an elective caesarean section, or by the anaesthetist who sees you on delivery suite if you're having it during your labour. Sorry, we're just looking for the next question. So Vicky has asked, how much higher is the chance of needing intervention such as forceps following an epidural? So if you look at the evidence, there is an increased chance that you may need forceps or ventouse delivery if you have an epidural in your labour, but there's no evidence that it makes it more likely that you need a caesarean section. I'm afraid I don't have the exact numbers to hand. I don't know if anybody else has got those. No, so it does slightly increase the need that you may need forceps or ventouse at the end of your delivery. But by somebody just telling me by about 10%, so you're about 10% more likely than if you don't have an epidural.
Okay, so there's some questions on the birth pool, and there's some questions on induction. So I think we'll end Jenny's bit just now, and thank Jenny for coming to talk to us. That's brilliant to be able to have the opportunity to ask these questions. And I'll just answer a couple of these questions while Mena comes over, because she's going to talk to you next. Emily, you've asked, are there any restrictions on who can use the birthing pool? You'd like to use it for your third baby who's due in 3 weeks. Emily, please can you ask your community midwife, because she will be able to guide you on whether it's suitable or not. We have a whole guideline with criteria that will enable us to answer that question. And there was a message from Siobhan I fast forwarded to past, and it wasn't because I wanted to ignore it, Siobhan, it was just because you said, if you have tested positive for Group B strep, would you deliver in the delivery suite? No, Group B strep in itself is not a reason to birth on delivery suite. We do advise that we give you IV antibiotics in labour to help protect your baby, but those can be given both on delivery suite and they can be given on the spires. So you don't have to come here, but obviously if you have an additional complication that means the spires isn't a good option for you, then we would recommend the spires. So let's just come back down to where we are. Somebody asked a question. You've got some questions for induction, so I'm going to say the name Rhian, and hopefully when Di comes, she'll remind me, and we'll come back to the questions about inductions when we get to there, because that's the ones that Di will be able to answer. So I'm going to introduce you to the lovely Mena, who's one of our obstetric consultants and joint lead of delivery suite.
Hello, so good afternoon, everyone. It's lovely to get the opportunity to talk to you today. I am one of the obstetric consultants here at the John Radcliffe, and there are a team of us, and I can assure you that at present we have very good staffing in the unit. So our role on delivery suite is that we work really closely with our midwifery colleagues and the anaesthetist to ensure that we provide safe care and we support your birthing processes. We hope that the vast majority of you will not have to meet us, but on occasion we are called into the room to come and help support your care. Now that might be for a number of different reasons. It might be just to review baby's heart rate monitoring trace, for example, but on occasion we are also asked to come in and give our opinion and try and make a joint plan with yourselves about any support you might need with the birthing process. So I was going to particularly just touch on what might happen in the event that you needed a bit of help and support with birth, in particular by an instrumental delivery. So usually we will be called into the room, we will come in and we will make sure that after having met yourselves, we get an update on your history. And then we'll tend to make an assessment so that we can make a joint plan in partnership with yourselves about what might be the next best course of action. That assessment often includes just reviewing your notes and your history, looking at what the course of your labour has been like, and then usually we would examine the tummy and then usually do an internal vaginal assessment. In addition to that, we'd be making sure that if baby was on a heart rate monitoring trace, that we were looking on the trace to check how baby had been doing. And then if it was felt by all of us that the next course of action would be that to help support you with the birth, that we would do an instrumental delivery. We would talk you through what the options were for you, make sure that you were comfortable. And unless it was an emergency, we'd make sure that we had adequate pain relief. We'd also be looking into the options of where the best location for delivery would be. So depending on what the findings were, both on when we examine your tummy and when we do the vaginal assessment and look at baby's heart rate monitoring, we would make a decision as to whether or not we stay in the delivery room for the birth or whether we think that perhaps going to theatre would be the best course of action. At that stage, we'd then also be talking to you about what sort of instrumental delivery we'd be doing. So whether that would be a forceps delivery or a delivery with a suction cup, a kiwi cup. Often our examination findings suggest that one of those might be superior to the other, but we'd be talking to you about that and answering any questions you had about that. Often when we do an instrumental birth, we will then be repositioning you. So it will be a change of position, making sure you're comfortable. We help with emptying the bladder. And then we go through a number of checklists with the midwife in the room at that stage. So that was the instrumental delivery. Anything else, Wendy, that you wanted me to touch on with an instrumental birth?
It's really important for you to work together.
Yeah, so we'd be working together as a team. And I just wanted to reassure everybody that though we'd been asked to come in, it's very often that I get called in and I actually act as a second midwife and we just help support a normal birth, sometimes with a change of position. We're very keen to try and make sure that we can make the atmosphere and the environment in the room as optimal for you as we possibly can. So that means lighting, depending on how you would prefer it and what's good for delivering if we're doing an instrumental. If you want music in the room, we definitely try to support delayed cord clamping and skin to skin as soon as is practical. So we certainly are very keen that we work together with yourselves to make that experience as nice as we can for you and as safe as we can for you all.
That's great. Thank you. So does anybody have any questions for Mena? So I'm just going to zip down. That's about induction. Lots of thank yous for Jenny. Thank you very much. We can try and answer some of these questions, I think. Just thinking where to start, because it's kind of all come a little bit in different things about induction round about it. So Yvonne, you've asked if you had a previous caesarean section, do you have to go to delivery suite or are you allowed to start in the midwifery-led unit? Yvonne, we recommend that you come to delivery suite to have your baby because we recommend continuous monitoring of your baby's heart rate in labour. We appreciate that we make recommendations that not everybody wants to follow, and it's important for us to have more of a discussion with you about why we recommend delivery suite and why we recommend continuous monitoring. So if this is the case for you, please can you talk to your midwife and she will know to refer you so that we can have a discussion with you in our mode of birth clinic.
Thank you for all your positive comments. There's lots of thank yous coming in for Jenny, definitely, and Rhian.
So, Krutz, your first labour was induced through a drip and you're currently 33 weeks. Is it likely that you'll be induced or can you still go to the spires? If everything is well, it's very difficult to comment when I don't know your history and things, but if you if there are no other complications, then you can go to the Spires. If you go in, Di will touch on again to reassure you that if you go into labour and you're otherwise considered normal and low risk, and you don't need to have the hormone drip, then you could go up to the Spires to have your baby, as we had a lady yesterday. So yes, it is possible.
So Blanca, we're just reading through your question.
So Blanca, you've said your first baby needed oxygen after birth. With your second baby, you're considered to be low risk. Your midwife is promoting a midwifery led unit for birth. You're just wondering what happens if there are unforeseen complications with an emergency cesarean section during labour. Basically, we monitor you the whole time when you're in labour. And if we suspect that there is a complication, things very rarely appear without any warning sign. So if we're monitoring you out in the community and we think there's a problem, we would transfer you to hospital where you could get the right care, and you'd meet people like the lovely Mena to make sure that you and the baby are okay. So, you know, I just want to reassure you, if your midwife is considering you low risk, it is as safe for your baby to be born at home in a community unit, in the Spires or delivery suite. So we've got a massive body of evidence that says it is as safe for your baby. The advantages to you, if you're a low risk woman, is actually you're less likely to have interventions and meet people like the lovely Mena.
So Gemma, you have asked, do you have to book into the Spires prior to your due date? So no, you don't have to book into the Spires. You would normally arrive onto the unit and then we would assess you. And then we, as far as I know, the Spires is well staffed, and you'd be able to go to the Spires. Lexi, you've written to say that you're supposed to be having your first obstetric appointment on Tuesday and you haven't heard anything. So currently we are continuing all of our antenatal clinics. What we have tried to do is we've moved from the face-to-face option for clinics for most women to a remote consultation, which would most likely be a telephone consultation. So those clinics are going ahead every day, and you should have been contacted to let you know that it would be either a telephone or a face-to-face. If you haven't, Lexi, it may be that we just need to coordinate with yourself. So perhaps Lexi can just let us know.
Yeah, well, on your letter, your appointment letter, you should have a number that you can phone. I would suggest that you phoned on Monday. And they will be able to tell you or signpost you.
So Gemma, you've asked if somebody does get taken to theatre, are birth partners still allowed to come? So yes, at the moment, in the event that we decide that we need to go to theatre for the birth, whether that's an instrumental delivery or a caesarean section, at the most part, we are very supportive that partners accompany you there. Obviously, this is an exceptional time, and in very few cases, if there is a real emergency, we would then maybe have to make the decision that your birth partner wouldn't accompany you. But at the most part, we are ensuring, and it is happening daily, that birth partners are accompanying people, and we will try our best to continue to keep that way. Ella's written in to say, do I have an epidural for forceps, or what other pain relief are you giving? It sounds painful. Our intention wasn't to scare you, I can assure you of that, Ella. So yes, some people will already have an epidural in place when we go in to assess them, but certainly we will talk through the pain relief options for you. They include the option of gas and air, and that may be a suitable option for some women who seem to be coping well and who perhaps we're doing a Kiwi suction cup delivery in. There are other options of more local pain relief that we can give as obstetricians before we start a delivery, but certainly making sure that you're comfortable is a priority for us, so we will talk through those options for you. Lucy's asked, can partners still come in? So for birth and on the delivery suite, partners certainly are allowed to come in, and that's one birth partner to accompany you. Wendy, would you like to talk about delayed cord clamping?
I'd love to talk about delayed cord clamping. So delayed cord clamping is something that we do traditionally. Many moons ago, we used to, immediately as your baby was born, we used to cut the baby's cord and progress very quickly to delivering your placenta. There's been a lot of evidence that shows that actually if you do that, some of the baby's normal blood volume that it should have after the birth is actually sequestered or kept within the placenta. So if we can wait for a minute or two after the baby is born, the baby will naturally get its full blood volume, so it's beneficial to babies. So lots of units do it routinely now. We do it here routinely. So we're making an assessment of that baby in the first minute. But even if you're given the drug to help you deliver your placenta, because the drug doesn't start working for 2 or 3 minutes, that's ample time for the baby to get its normal blood volume, so it doesn't affect that physiology. So it's all about making it a positive experience for you and your baby, enabling that skin-to-skin contact, and it's beneficial to your baby.
Okay, Lisa, you've asked what the reasons would be to have an instrumental birth. So there's a number of different reasons to have an instrumental birth offered to you. One of them would be that there might be a delay in the labour process, so you may have been pushing for quite an extensive period of time, and it appears as though there is support required for that delivery to take place safely, so we might talk you through an instrumental birth in that situation. It might also be because there's evidence when we're looking at baby's heart rate trace that baby is getting very tired, and therefore we would discuss with you the options for an instrumental delivery then. But there's a number of different factors that would come into play when we make that decision, and we'd be doing it in partnership with yourselves. We've got a couple of questions. Jessie, thank you. Mena, you were lovely when I came in near Christmas. Thank you. Rebecca, my daughter's being induced on Monday with her first baby. I will be her birthing partner. At what stage will I be allowed to come in with her? So as far as the induction process goes, I'm going to let Di talk you through what that process is like. But at the point at which we either say that you're in established labour, or we're going on with the next steps of the induction that involve coming down to delivery suite, that's the stage at which a birthing partner would be invited in. Michelle has said, if you've had 2 previous forceps delivery in theatre, is it likely to happen for the 3rd time? So I would say that there is always a possibility of needing some support at some stage in labour, but certainly there is absolutely no reason why we would not be hoping that you would come in and have go into spontaneous labour and have a normal birth. Anything else?
I think that looks like it.
Thank you. So Kritz has said, thank you so much. I'm considered low risk for now. Yeah, and we would agree with that as well, Kritz. Thank you. So we're going to hand you over now.
So I'm now going to hand you over to one of our other delivery suite leads, Sujay Chakravarti, who is going to talk to you about caesarean section. So we're all just swapping round and trying to social distance and answer
just going to adjust the screen. Hi, good afternoon. I'm going to talk to you a little bit about caesarean section. The first thing to say is it is a major intervention, and it is something that we would only perform if there was a clear indication to do so. Caesarean sections may either be planned caesareans or they may be emergency caesareans in labour. In either case, we would always involve you and your partner in the decision to do so. And we would talk you through the options that were available, and we would together as a group, as a team, decide what was the best option available to you. If the decision is to have a caesarean section, then we would go through a consent process in the room. And after that, we would transfer you to theatre. Now, we are aware that theatre can be quite an intimidating environment, and our staff are trained to try and make it as pleasant as possible for you. There will be a number of people in theatre, and I think during the current pandemic, you must be aware that staff will be wearing extra protection, and there may be occasions in which you may be asked to wear a mask as well, and that would depend upon the individual circumstances that led to the cesarean section. In theatre, we go through a checklist and we talk you through the different things that would happen. Now, women are very keen to have delayed cord clamping and very keen to have skin to skin as far as possible, and we will do everything possible to facilitate this for you. Now, depending on what the indication for a cesarean is, there may be a pediatrician present in theatre as well, and it is possible that the baby may need to go to the pediatrician before baby is then given to you. But cesarean sections are, in general, very safe procedures. It's something that we are trained to do and something that we do lots and lots of. And so I'd like to reassure you that it's very unusual to have a significant complication at a cesarean section. Currently, if everything goes well, then women will transfer to the postnatal ward in about 2 to 4 hours after they've had a cesarean section. And we currently plan for all women to go home the day after their cesarean section, unless, of course, there's a medical indication for them to stay longer than that. I think that's about it in terms of what I want to say about cesareans, but there are lots of us around at the moment, and as Jenny was saying earlier, our staffing has been arranged to ensure that there are a lot of senior clinicians around to ensure that we continue to provide a safe service.
Great. So we're just going to invite further questions for Sujay before we move on to Di. You should see Di taking a big deep breath, honestly. We're making her nervous. Okay, Yvonne.
So you had a cesarean section, your daughter was caught around the neck 5 times. What are the chances? So the cord being around the baby's neck is actually not that unusual, and we do know that about 10% of the time the baby's cords are in the vicinity of the baby's neck. It is quite unusual for the cord to be around the neck 5 times, but the cord being around the neck in itself is not something that leads to your baby getting tired. So it is possible, like I said, about a 10% chance that this may happen again, but it is very unusual for that in itself to lead to a baby being distressed.
Lots of nice positive comments. Yep. I need to have Jenny on.
Yes, in the answer to the oromorph, it is usually the first 24 hours that women may require additional pain relief to paracetamol and ibuprofen. And so if you are requiring oromorph for more than 24 hours, then absolutely you would remain in hospital for that period of time.
Okay, so you're asking questions about midwife severity. So you said, how many women do midwives look after at once at the moment? And is it more than one? And are there staff shortages of midwives? Verity, I'd like to reassure you that we have juggled around midwives and where we have very positive numbers of staff available. We provide one-to-one care in labour. It's something that we're very passionate about. So when you are in established labour, you predominantly just have one midwife looking after you. Sometimes there is an additional student midwife working alongside your lead midwife. And then obviously you might meet another midwife when the midwife goes for a break, because we always make sure that you have a midwife with you when you're in established labour. If you, for example, you're up on the ward, on the postnatal ward, you won't need one-to-one midwifery care by that point. So you would have, there will be some midwives available for you. And if you're in the induction of labour bay, Di will go on to tell you that basically there can be you and 3 other women that Di's looking after at a time.
So there's a question here about having a conversation with a consultant next week following a difficult birth last time. Yes, absolutely. You would sit down, well, or maybe a face-to-face conversation or a telephone conversation, and your options will be discussed. And absolutely, if between you feel that a cesarean section is your best option, then absolutely we will book one for you.
So Emma, you're asking a COVID-related question. You're saying currently are the staff in the Women's Centre kept separate from the main hospital to reduce risk? Emma, we're not deliberately kept separately, and some of us have chosen to go over to the main hospital to help them if we have nursing experience. And you know, because we're following rigorous personal protective equipment standards, we don't feel that that's putting you more at risk for us working in maternity, but predominantly most of the midwives just stay in maternity.
Rhian, you have a question about gestational diabetes and whether that carries a high risk of a cesarean section. It's very difficult to answer that question as a generalization because there may be individual factors that play into this. Sometimes with gestational diabetes, you may grow a bigger baby and that may lead to a conversation about what is the best option for you. But in general, it will depend on whether you go into spontaneous labor or whether your labor is induced. As the evidence is emerging, and this is separate from COVID, we are delaying inductions of women with gestational diabetes, and we're not inducing women as early as we used to. And we do know that if you go into spontaneous labor, then your risk of having a cesarean section is lower. I hope that answers your question. But there may be circumstances specific to you that need discussion with your consultant.
And I think that's most of the questions now for Sujay. So thank you very much, Sujay, for coming today.
Thank you.
I'm going to introduce Di now, who is our lead midwife for our induction of labour suite. So the most knowledgeable one of all. So I shall introduce her, make her laugh. She's very nervous, so you send her lots of love hearts.
Hello everyone, I'm Di. As Wendy said, I'm one of the induction midwives that work up on level 6. I just really wanted to talk you through the induction process and what will happen when you come into us. So initially when you're booked for an induction, you'll get a phone call and they'll give you a provisional date. At the moment, because of the situation, you will have some other questions that you need to answer. Obviously, hopefully most of you are self-isolating. That's been the advice that's been given. And then what I'll do, or one of my other team will do, is give you a call the day before your induction and give you a time to come in. We usually stagger them hourly, so you will always come in the morning. So it'll either be 8, 9, 10 or 11. And then we're up on level 6, so on the antenatal ward up there. And you'll come in, it's a 4-bedded bay. Obviously, if we try to accommodate people if they're particularly anxious and want a side room, obviously that's not always possible, but as predominantly it is a 4-bedded bay. You'll then go on one of the monitors that Rhian has shown you earlier. I don't have the need for the telemetry up there because obviously women aren't on the monitor for long enough, so it is one that is on a wire, so you will be having to stay kind of on the bed just at that point, and you'll be on it for between half an hour and an hour. And once we know that baby's fine and is safe for us to proceed, then either myself or one of the team will examine you. Some of you may have had a stretch and sweep, so it's very similar to that. And then depending on what is going on with your cervix, how dilated it is, if you need the prostin gel, then we'll give you the gel at that point. And you just have to lay on your side and lay still, because obviously if you stand up, the gel's going to come straight out. So you just have to lay still for half an hour. Monitored. And then after that, you're free to get up and walk around. At the moment, we're trying to discourage you from going outside, but obviously, you know, you can walk around the ward. There's a day room up there that you can go and sit in. We've got birthing balls up there that you can use, and there are a number of things that we can help you with in terms of pain relief up there. Obviously, if you're beginning to need more pain relief such as Entonox or anything else, then that's the point that we would transfer you. At the moment, obviously partners aren't allowed to come in until you're in established labour. So you'll come up and you'll have myself and one of the maternity support workers that will look after you until you get to established labour, and then we'll transfer you to the spires or down here to delivery suite. We literally listen in every hour, and we'll do that for 6 hours once you've had the gel. And it is literally what your community midwife does. It is just listening in with a Doppler. We don't keep examining you. We kind of know when you're in established labour. You will know as well. And then after 6 hours, if you're still with us, then we reassess you. So we'll put you back on the monitor for about another half an hour. And then depending on what you're doing, we will either give you a second prostin gel, or at that point we will see if we can break your waters. Now, the breaking your waters is really dependent on what's going on the rest of the hospital. As a rule, a lot of the time we are able to do that, and then we'll transfer you, again, like I said, once you're established or you're not able to cope any longer. I think that's... Is that for everything?
Take to sort of the hormone drip and things.
Hormone drip, if you have your waters broken, we can give you 2 to 4 hours up on the induction bay. As long as your baby stays fine, as long as you're both fine, then we can give you that time to get yourself into established labour. If at that point then you're still not there, then we do need to think about transferring you to delivery suite. And at that point your partner can come in, whether you're in established labour or not, and you would then have to start the hormone drip. So that would be on the monitor. But again, as Rhian says, the telemetry is here, so you can still stay as mobile as you want to be. So, okay.
That's great.
Yeah, is there any questions at all?
Let's see where questions are. I think we had to go back to Rhian or something at some point, unless you want to repost Rhian. So lots of nice people saying hello. Thank you. Lots of appreciation of what we're doing, and we're really pleased. We're doing this for you. We want to make this as positive an experience as we can for you. So let me go back and see if I can find Rina's comments about induction. If not, I can look back later. Maybe if you could repost it, Rina. If not, I can. Oh, there we go. Rina, you asked, can a request still be made for an induction given the circumstances at the minute? Because you're quite anxious about going into labour. Rina, we're really trying to encourage people not to be induced unless they really have to be induced, because you are in hospital obviously for longer. I appreciate that you are anxious, and we'll do everything that we can to look after you, but we would encourage you to hold off and wait for natural labour to occur. So, you know, do look up some nice hypnobirthing techniques, mindfulness techniques, try to manage your anxiety a bit, because generally going into labour naturally is the best thing for you and your baby. There's another one about... And I think, Lucy, I think Di answered your questions about partners coming in. So they're going to come in once you either go up to the spires or down to delivery suite. So I think we covered those questions in induction. Oh, and then you post some more. Okay, so we've got, do you still go to level 6 if your baby's being induced via your waters, your 6th baby? Vicky, you know you would come into delivery suite. So what would happen is the midwife, when she called you the day before, she may ask you to come to level 6 for some monitoring first. Or if she's spoken to delivery suite and Rhian says, actually, it's okay, you can come straight here, we can adapt along the way. It really just depends whether delivery suite have space and a midwife to be able to do it straight away, or whether Di can help do some monitoring and things.
Yeah, sometimes people do come up and just have to hang with us for a while up on level 6. So.
And actually, that's a good point to just talk about some delays that can happen in labour. We appreciate that, you know, when you come in to be induced, you want it to continue, and it can be frustrating sometimes when we say, I'm sorry that we can't start your induction yet. That is really just to keep you safe. You know, you are not actually in labour, and it's much better for us to help the women who are in labour to give birth and ensure that somebody is available to look after you when you are in labour. So a delay may be really important for you. So although it's incredibly frustrating, please bear with us. We will do everything we can to continue with your induction when it's a safe time to do so. Can you read them? Do you want to do them? So I think, Sophie, you're talking about women who labour quickly because your third child came very quickly from when you came into hospital. I think when you talk about babies happening quickly, Sophie, it is good for you to explore with your community midwife that actually, depending, I don't know any of your previous history, but actually it might be safer for you to plan a community birth rather than coming into hospital if your labour is very quick. Siobhan.
As a rule, no. You're asking, can partners still come in and check in for induction and help with luggage? No, at the moment they can't. So basically, what we're saying is just bring in what you need to keep you comfortable for the day. Obviously, things for the baby and car seats and things like that, just leave in the car, and your partner can bring those in once you're moved down to delivery suite or up to the spires. Obviously, if you do come in with loads, then we can always come down and meet you and help you with that. But obviously, your partner won't be able to come in and one, book you in, or two, help you with the luggage. So all I'm saying to ladies is just bring in some snacks and things for the day, things to read and do, and things that are just going to make you comfortable. So hopefully you can kind of keep that and condense that down to one bag that you can manage, all right? Does it still mean my partner wouldn't be able to come in? So again, I think we've just touched on that partners won't be able to come up onto the levels, but once you transfer, then they can come in, and I normally take a phone number and give them a call once you're being moved, okay?
So Marissa, you've asked how long do the hormones, if you have a hormone drip, stay in your system for? And the hormones do leave your system, relatively quickly. They have a short half-life. But obviously it depends how many you've had, so it's very difficult. It's a bit like how long is a piece of string. It's very difficult. It depends how many you've had, how long that will work out your system. But I think from stopping oxytocin,
15 minutes. Half-life is 15 minutes.
Yeah, half-life is about 15 minutes. Sorry, I'm just asking Sujay. Good to have somebody in the corner. So Emma's asking about the hormone drip. Would it be done as a first instance? Emma, a hormone drip is used in the first instance if your waters are broken and we're inducing you. So we generally induce people if their waters are broken. The majority of people choose to be induced between 36 and 72 hours. Some women choose to be induced earlier. Some women choose to not be induced at all and wait, and that's fine. And some women, we actually recommend that they have their baby sooner than 36 hours. For example, if there was meconium stained liquor, or for the woman who had group B strep, those babies we would encourage an earlier induction. But generally the women that are induced between 36 to 72 hours, we would use the hormone as the first port of call. And unfortunately you can't have the hormone drip on the spires because you need to be continuously monitored to make sure baby's okay during that process.
Okay, Luann asking about harvesting colostrum. Yes, you can bring it in. If it's frozen, then obviously just let us know as soon as you bring it in, because we'll put it straight in the freezer. Your husband can bring it in. Whatever really you want to do is fine with us. But just be aware that it does defrost really, really quickly. So if you bring it in, just make sure that the induction midwife has given it straight away, and then she can pop it in the freezer for you, all right?
Thank you for your positivity.
And this alternates away. How will we know when to call? Okay, so Katie's asked that obviously you live quite a distance away. Obviously, at the moment the traffic is fine, so we're finding that people are managing to get in quite easily, and this parking is certainly much better as well. So what we'll do is, we'll know in terms of when we think that you need to get your partner to come in. And obviously if it's, I don't know if it's your first baby, so first babies take a little bit of time, so generally partners have got that time to come in. If it's your second or third baby, then they come a little bit quicker. So, you know, we always try and err on the side of caution and get them in, you know, a little bit sooner, even if some people have been sitting in the cars and the partners have been sitting there and waiting in the car park. Obviously that's not ideal if it's all day, but certainly if we think that things are getting on, then it might be worth that we would then give him a call and say, just come in and just stay in the car for a little bit until we give you a call, and then he's here. All right.
Jessica, it says, are there any tighter restrictions on women being appropriate for the spires? We haven't changed and haven't felt the need to change any criteria for the spires, so the criteria remains. If you feel that your pregnancy is slightly higher risk, then please, or you're unsure, please talk to your midwife, because she will know what we can support and what we can't. So I'm going to finish here. I think there has been another comment, but we're obviously way past our time and I have to let this lovely team go and get back to work. And the lovely Jenny who came in on a day off, so we have to let her go back and have her day off. So thank you very much for today. It's been great having the chance to talk to you again. I'm going to have a wander up the corridor. I might lose signal. If I do, I was hoping to be able to show you some more of our team so that you can see that we're all here. But otherwise, we will see you next week when we talk to you about after you had your baby, how you will be and your baby. So thank you to everyone.
Bye.
There you go.
Bye.
That's brilliant. There you go. So I'm just going to walk you up the corridor. You're only going to get to see behind me. And as you can see, there are various people about, some more of our team. There you go. You can see that everybody's wearing masks apart from me as I walk up the corridor. We are having some building work done at present, so there can be some banging and noises going on. Delivery suite is generally just a little bit noisier. And I'm just going to turn around and show you our team, lovely team, sitting ready for you. Yeah, there you go. All happy and smiley. And I'm going to shoot up to theatre. So generally we're all about waiting to see you, and we're going to come up to theatre because I did promise you might be able to see theatres. Can I go into theatre? Is there somebody in theatre? Okay, so we're going to come into theatre because some people said that they found it quite daunting. This is a member of our team. There you go. See? Lovely, friendly faces. And if we go in, because we don't want you to find anything frightening, and theatres can seem, they're very bright white spaces, but if you can look about behind me, because I haven't got my tablet, she says, can you see that there are? So there's a big light above where you would lie, and if I can show you, that's the couch that you would lie on. And there's lots of equipment round in the back, and it can seem quite scary, but everybody is going to be in here smiling and reassuring you as to what is going on. So it's quite a big space. The top end is where the anaesthetist is, and all the stuff is there that they need to support you. And then we are doors out of theatre. And again, we have another one of those resuscitators just in case we need it. So I hope you can see that, you know, we're trying to show you everything so that you don't feel quite so scared when you come in. We're all here to support you and make your birth as positive an experience as possible. So thank you for joining us this week. Have a good weekend, and we will catch up with you next week when, like I said, we're looking at more what happens after the birth of your baby. So thank you again.